Hi everyone, my name's Tom Hills. I'm an infectious diseases physician and clinical immunologist in Auckland, New Zealand. I'd like to talk to you about the influenza immune modulation domain, a new domain in REMAP CAP. And this domain is approved here in New Zealand, it's approved in the UK, and we're excited to see more and more regions coming on board. Here we're looking to build on knowledge from the pandemic and apply that to other viral infections and evaluate whether these therapies, tocilizumab and baricitinib, which are effective in severe COVID-19, are effective therapies in severe influenza. The reason we're interested in doing that is that there are similarities in terms of the immune response in patients with severe COVID-19 and severe influenza. Interleukin-6 is a critical cytokine in that host response to these severe viral infections, with IL-6 levels being highly elevated in both severe COVID-19 and severe influenza patients. High IL-6 concentration associated with disease severity, mortality, inversely associated with arterial oxygen levels in hospitalized influenza patients. It's not clear whether those high IL-6 levels are a marker of disease severity or a mediator, whether that IL-6 is involved in the pathophysiology of severe influenza infection. Because of the findings in severe COVID-19 patients, we're very interested in evaluating these immune modulatory therapies in severe influenza. So we propose evaluating no immune modulation versus tocilizumab versus baricitinib. Tocilizumab will be familiar to many of you as an intervention that was studied in the IM1 COVID-19 immune modulation domain, where many patients were recruited from the UK, and it was evaluated alongside a similar IL-6 receptor antagonist called sarilumab, and both were shown to be very effective treatments for severe COVID-19. Baricitinib is also now widely used as an approved treatment for patients with severe COVID-19. This is another medicine that we're repurposing from the outpatient clinical immunology rheumatology world, where it's used for autoimmune diseases and atopic diseases, and it inhibits the downstream signaling of cytokines like IL-6. It's also effective in severe COVID-19, as demonstrated here in a figure from the recovery trial. So our question is, does treatment with these immune modulators, tocilizumab or baricitinib, improve outcomes for critically ill patients with severe influenza? The inclusion criteria reflect the approved use of tocilizumab and baricitinib in severe COVID-19. So we're constraining this to patients who are at least 2 years old. They're in the severe state of REMAP CAP, so critically ill receiving organ failure support. Influenza virus infection has been confirmed by microbiological testing, and influenza virus infection is the reason the patient's in the severe state, rather than they're in a critical care unit with trauma and happen to have influenza. We exclude patients who have SARS-CoV-2 infection because these agents will be standard of care for those patients. And then we have some other exclusions, again, based on the use of these drugs for COVID-19, such as significant immunosuppression, an invasive infection with something like a bacteria or fungus, or people have already received these drugs or a related drug. Importantly, if patients are pending the result of an influenza test, they can be enrolled, and then their treatment assignment can be revealed once those test results become available. We understand that some patients may be enrolled in the platform and receive treatment allocations in other domains where the influenza testing information is not required, and this domain is something that they can be enrolled in, and their treatment assignment can be revealed using a delayed reveal when the influenza test result becomes available. Dosing of tocilizumab is as given for patients with severe COVID-19, 8 milligrams per kilogram up to 800 milligrams for adults, and we're giving a single dose. A minority of COVID-19 patients in studies and in clinical care may receive a second dose, but we're evaluating a single dose here. Pediatric dosing is the same as adults for children who are at least 30 kilograms, but children who are less than 30 kilograms have a 12 mg per kg dose. And again, this is in keeping with the approved dosing for COVID-19. Baricitinib is an enteral medicine, and its dose depends on renal function, so there are some EGFR bands there, and this reflects the dosing used for COVID-19. And in children who are at least 9 years old, adult dosing is being evaluated, and in children who are less than 9 years, as with clinical use of baricitinib for COVID-19, we use a slightly lower dosing. The primary endpoint will be the same as for other domains in REMAP CAP as defined in the core protocol. Important secondary endpoints for this domain include positive blood culture results for bacteria or fungus that identified more than 48 hours following randomization. And pulmonary aspergillosis diagnosed more than 48 hours following randomization. There were not significant safety concerns in terms of secondary infections when these drugs were used for COVID-19, but influenza is different, and there may be higher rates of co-infection in patients at baseline, and we felt it was prudent to collect information on secondary infections using this definition of blood cultures and pulmonary aspergillosis as key clinically relevant infections, and we want to evaluate whether there is any increased risk with these agents, contributing more to the data on the safety of these drugs in critically ill patients with viral pneumonia. I'd like to thank you all for your time and for your interest in this domain, from down here in the bottom corner of this map to your team all clustered in the middle at all those sites in the United Kingdom. I'd like to thank you for all your work recruiting patients, and please reach out via the team in the UK if you have any questions. Thank you.